Hey guys, welcome to Anesthesia Part 1. So guys, before I start with our whole topic of anesthesia, I want to know how we are going to approach the subject. So whatever I had studied for my June Fmge exam, we are going to talk all about that. The portion is going to be very simple, very enough amount of which you will be able to solve many of the PYQs and the new questions to come. So these topics along with 5 years of Fmge, 5 years of NEET PG and 3 years of INA are good enough for at least anesthesia subject to score at least out of 5 questions. If there will be there at least 4 questions you're being solid strong. Okay, so without further ado, let's start with anesthesia part 1. So guys, before we start with any of the drugs, let's talk about what is anesthesia, guys. Remember, first thing, anesthesia is a temporary, not a permanent, a temporary loss of sensation. A temporary loss of sensation of what type of sensation? It is going to be pain. Now, why pain we have to stop? Because guys, you need to know pain is a sympathetic stimulation. Since pain is a sympathetic stimulation, what it's going to do is it is going to increase and release adrenaline and noradrenaline. And as you all know, what are the roles of adrenaline and noradrenaline? It is going to increase the heart rate, it is going to increase the blood pressure, and it is also going to increase the respiratory rate. In short, it is going to increase the workload on the body system. So whenever you do any surgical procedure, any diagnostic procedure per se, you know that if there is pain in the patient, if obviously you're going to have a cut, it is going to hurt, it is going to increase the heart rate, BP and respiratory rate. So thereby, because of our body's defense mechanism, all these heart rate, blood pressure, respiratory rate is going to increase. Thereby, it increases the severity and the prognosis of the patient is going to be poor. So because of which we have something which is anesthesia. If you numb the pain, if there will be no pain, no stimulation of the sympathetic system, no stimulation of noradrenaline, thereby our system is going to be stable. So in short, anesthesia is to reduce the workload on the body system. Okay. Whenever we talk about anesthesia, why do we need it is we need an important thing which is your pre-anesthetic checkup. Basically, either it is going to be an elective surgery or an emergency, you have to see certain parameters after which only you can issue the go for the surgery. If a patient is provisionally fit, by provisionally fit means there are some parameters which are up and down, but these can be corrected, which is optimization. So what are you going to do? And the changes, you're going to advise them some medications or pre-medications. Then you go on with the surgery, which is also having anesthesia in it. At the end of the surgery, post-operative care also includes the whole thing of anesthesia. Okay. So whenever we talk about its plan, in the plan of anesthesia, the first thing which you will see is what are the things we use. For example, if you're talking about general anesthesia, in general anesthesia, you're going to sedate the patient with the help of multiple inducing agents. Before we start anything, the first thing which we have to do is we have to secure an IV line. Why IV? Why not IM or sub-Q? Because IV line is going to give you 100% bioavailability. The role of inducing agent over here is to give sleep. So if you induce sleep, after which you have to basically it paralyzes all the muscles including the diaphragm. So for which you need now an airway management. Now this airway management can be done with the help of endotracheal intubation or laryngeal mask airway. Along with this, so that our airway management can be smooth, we are going to give a muscular relaxant. So first we did an inducing agent, then we did airway management, which is facilitated by a muscular relaxant. And so that whatever role of our inducing agent after our surgery is done, we have to reverse it back. So usually reversal is done by drugs like neostigmine, and especially at the time of extubation. Okay, so basically what we are doing is a monitored anesthetic care. This is not only done for major surgeries, it is also done for small diagnostic and therapeutic procedures. This is something which is general anesthesia, in which you use drugs like the IV drugs basically. In regional anesthesia, you have two types of regional anesthesia. Okay, so in regional anesthesia, you have central and peripheral. Examples of central are spinal, which is basically subarachnoidal, epidural and caudal. On the other hand, peripheral will be a brachial plexus block, a femoral block or a intercostal block. Okay, so these are the classification of the basic things which will be. We'll start with basics and then go on with the drugs later on. So guys, as I told you, the most important thing is going to be secure an IV line for 100% bioavailability. Now, whenever you're securing an IV line, you will see over here, this numbers 14 to 26 are nothing but gauge. You notice one thing, as you increase the gauge, the flow rate is decreasing, which means the smaller gauges, which is the larger needles, which are basically 14 and 16, they are going to have maximum flow rate. You can see orange is having 270, while if you see gray is having 236, which means whenever you want to do anything like fluid resuscitation in case of emergency, so what are you going to use? orange or gray like a IV size cannula is going to be used. Okay, green, which is there, number 18, green will be usually used in case of males. Okay, for normal IV drug use like ceftriaxone or something like this. Pink is going to be done for females, while you will see blue is something which will be done for fragile patients like child or elderly age. Okay, along with this, yellow is going to be used in the NICU care, especially for a term child, while if you will see 26 is going to be used in NICU care for a preterm. Now what you have to usually, what people remember is 14, 16, 18, and they remember also the colors which will be there, right? You can remember this by, oh great God, please bless your people. Violet or purple will be the people. Okay, so this is a mnemonic in which you can remember the order. But very important thing nowadays they're asking is the flow rate. So you have to remember the flow rate. So how I remembered it is again practicing every day, you will be able to be getting up easy as well. 270, 240, 103, then something around, you can remember approximate as well. So I remember approximate 70, almost half of it 40, half of it 20, and then 13. So this is almost the order. Last time they asked for green, which is 103. So make sure you know the flow rate as well. Okay. So over here, which we discussed last time in medicine as well. So remember here, which we already discussed, fluid resuscitation, maintenance, child and NICU. Okay. Next guys, we'll be talking about, so we are done with your inducing agents. And now example of inducing agents, which I told comes under general anesthesia. Few of the drugs are thiopentane sodium, propofol, etomidate and ketamine. We're going to talk about the pathophysiology, all the side effects, everything in detail in the following videos. Then we use inhalation inducing agent as well. One is IV, another one is inhalational. All the thanes, which will be halothane, isoflurane, desflurane, sevoflurane, the older ones which earlier we used to use, like the first drug, like first successful use of anesthesia, ether and chloroform. But then there were many of these complications due to which we have stopped them and started the new ones, which are the inhalation inducing agents. Okay, so the next thing is, once you give the inducing agent, then we talked about airway management. The airway management can be done with the help of intratracheal intubation or a laryngeal mask airway insertion. This will be facilitated with a muscular relaxant. Now in broad spectrum, in this video we're going to talk about broadly everything, right? So in broad spectrum of a muscular relaxant, you have two types. One is going to be a non-depolarizing one, and the other one is going to be a depolarizing one. Basically depolarizing we'll talk much more later in its main pathophysiology. I just want you guys to know an overview what we are going to discuss in the whole anesthesia session. Non-depolarizing, you should remember drugs like pancuronium, and just another MCQ, pancuronium are the longest acting ones. Okay, vercuronium and atracuronium will be there. Two drugs like atracuronium and cisatracuronium are the ones which are going to be degraded by or metabolized by something which is known as Hoffman degradation. Okay, everything in detail we will be talking about in the further videos. I just want you guys to see this now. If you don't understand, it's okay. Next time when we'll discuss this in detail, it will be having a picture type memory that you remembered, yes, we talked about this. And in depolarizing, a very important one is going to be succinylcholine. Okay, now another PYQ which usually they can ask is, what are the history related to the anesthesia? Remember guys, Oliver Wendell Holmes was the first to coin the term anesthesia. Okay, remember who? It was Oliver Wendell Holmes who was first to coin the term anesthesia. Joseph Priestley was the one who discovered oxygen and nitrous oxide. Okay, oxygen and nitrous oxide was discovered by Joseph Priestley. You had a person named Horace Willis. He was the first one who unsuccessfully demonstrated anesthesia using what drug, they might ask. That is going to be again nitrous oxide. So this was unsuccessful, remember, okay, unsuccessful. So if they will ask you who was the first successful one, that is W.T.G. Morton, who is known as the father of anesthesia. Okay, father of anesthesia, that is W.T.G. Morton. He was the one who successfully demonstrated the role of anesthesia with the help of ether. And remember what is going to be the World Anesthesia Day. It is going to be 16th of October. And when did he demonstrate it? It was on 16th of October 1846. Okay, 16th of October 1846. You had our Game of Thrones legend Jon Snow, who was popularized by the concept of obstetric anesthesia. He gave anesthesia to Queen Victoria during her 8th delivery. Just remember this fact that Jon Snow was the one. That's why at times if you ask the father of anesthesia in British areas and all, they will consider that as Jon Snow. But remember, W.T.G. Morton is the one who we consider as father of anesthesia. August Beer. August Beer was someone who drank beer, and then he was the first one to produce spinal anesthesia. Okay, first one to produce spinal anesthesia by drinking beer. Carl Kohler, C for Kohler, Kohler light cocaine. So that is why he was the first one to produce local anesthesia using cocaine. Okay, Carl Kohler, C for Kohler. Harold Griffith was the first one to discover muscular relaxant. Okay, and if they will ask you what muscular relaxant, he discovered D-tubocurine. Okay, so these are the ratifying. Anesthesia is all about ratification, many details which you just have to mug up, and that is why we're bringing this series, so that you know what you have to mug up and what you don't have to mug up with respect to the weightage of question. Okay, so these are the names which I want you to mug up for sure. Okay, next guys, let us talk about pre-anesthetic checkup. So what is the goal, they might ask, in case of in arts and science of medicine. So the goal of a pre-anesthetic checkup is so that the patient can safely tolerate the load of anesthesia during the planned surgery. So thereby what we are doing is, if we make this we maintain our we see that the patient is able to tolerate it, thereby it reduces the risk during the perioperative care. Perioperative care means before, during and after. Okay, what does a good pre-anesthetic checkup include? Whatever we basically need to do as a doctor, which is a complete history, physical examination, systemic examination, and an airway examination. So then an additional thing which you remember in pre-anesthetic is going to be an airway examination. These are few things which you just have to remember, read in mind. If they might ask which of the following is accept or not, I just saw one question, so then maybe this can come as well. Remember, PSC is a dynamic thing. Okay, it is very similar to the routine history. It includes our demographic details like name, age, sex, address, and then the chief complaint is something which is narrated by the patient. Okay, so this is as usual, which we do a normal history taking. Next guys, let us talk about conditions why are we doing pre-anesthetic checkup. For example, hypertension is the first topic which we're going to discuss. Why do you think in a hypertensive patient who's taking hypertensive drugs, why do you have to do a proper pre-anesthetic checkup? Is because if a patient is using any hypertensive drug and all of a sudden we don't taper the dose or we don't stop the dose, there can be a sudden fall in blood pressure, which is hypotension, and this hypotension can cause conditions like it can dysregulate our hemostasis, it can cause cardiovascular abnormalities, stroke, and even acute kidney injury. All right, so that is why this all things are written in the pathophysiology. You can see this in the PowerPoint later. I will send the PPT in the group. Okay, so what are the advices? You can continue all the hypertensive medications except for angiotensin receptor inhibitors and angiotensin receptor blockers, which will be there, because these can cause exaggerated hypotension just before the surgery. So stop it basically around 2 to 3 days before. Okay, if you can use another drugs rather than this. So this is the management. If you ask what is the clinical tip, if they ask you, remember, okay, if a patient is like having a small surgery like a cataract or in a breast fibroadenoma, you don't have to taper the dose or stop the dose early. You can continue with ACE and ARB. Okay, so just remember this. Next condition guys, diabetes. Now what are the severe acute complications you know about diabetes? One can be obviously acute, which is diabetic ketoacidosis, correct? Then when there is so much amount of osmolarity as well, so hyperglycemic hyperosmolar coma. And third one, when the glucose falls very down, and which is the most dangerous one, that is going to be hypoglycemia. Now hypoglycemia, why it is dangerous amongst these three is because when the patient is under anesthesia, all the signs and symptoms of hypoglycemia is going to be masked. Okay, so what they say is all the oral hypoglycemic agents and insulin should be stopped till the day of surgery. If a patient is taking any drugs like the SGLT2 inhibitors, it is preferable to stop that 1 to 3 days before the surgeries. If the patient is having a long-acting insulin, guys, a clinical tip, if a patient is having long-acting insulin, we are going to reduce its dose to 1/3 during the surgery so that the random blood glucose can be maintained between 120 to 200, and also they prefer short-acting insulin at the time of surgery. Everything is written over here, so just make sure that you're trying to understand whatever I'm saying. Next condition guys, epilepsy. Now all the epileptic drugs should be continued till the day of surgery. Why? Because obviously what if all of a sudden he or she throws a seizure, right? But the side effect of epileptic drugs are it affects the LFTs. So that's why make sure you check the LFT. Why? Because anti-epileptic drugs are enzyme inducers, okay, due to which they are going to cause some damage to the liver. So make sure you check the liver function test. If they ask you guys, epilepsy basically means continuous recurrent repetitions of seizures. How is a seizure caused? A seizure is usually caused by when there is less oxygen, that is hypoxia. When there is too much carbon dioxide, that is going to be hypercarbia, due to which a patient might suffer from acidosis as well. So three conditions: hypoxia, hypercarbia and acidosis. What is your management in case of seizure? If your patient is outside the hospital and you saw a patient is seizing, first thing what you have to do is you're going to put the patient in the left lateral decubitus position. First thing first, okay, they have asked this in the NEET PG 2023 as well. The second management is going to be jaw thrust, basically from the posterior mandible over here. You can see the details over here. Main thing you need to know, you place a finger posterior to the mandible of the jaw and apply an upward and forward pressure. Okay, so jaw thrust is also done as well. If you're inside the hospital, along with these maneuvers, you have to give now the dose. The first line of which they prefer usually is injection, which is midazolam. Another question they asked is, in case of maintenance, what do you give? You give usually phenytoin sodium. And not only that, they have asked in case of in UPSC exam, they have also asked what is the dose. You are going to give 15 to 20 milligram per kilogram diluted in 15 or 20 milligram per kilo diluted in 100 ml of NS. And for how long? It is going to be for 45 minutes. So try to mug it now only in case of seizure. Either first one is going to be injection midazolam. Otherwise, if they'll ask you what is the maintenance, it is going to be around 15 to 20 milligram per kilogram of phenytoin. And in what dose? It is going to be in 100 ml for 45 minutes. In case of anesthesia, few of the drugs with anesthetic drugs can cause seizures. Example of them are enflurane and methotrexate. Okay, enflurane and methotrexate can also cause seizures. Okay. Next, guys, if you have any patient who is having any coronary artery disease, maybe he had a history of MI, maybe he has blocks a lot, so you know that they will be they will be using any blood thinners. Example of blood thinners can be aspirin, clopidogrel, or warfarin. Now, what does blood thinners do? Basically, prevent the risk of clots. So you guys know if you continue these doses during the surgery as well, you can have bleeding. And this bleeding can go in severe places like spinal hematoma, which can further go and impinge nerve and cause paralysis. Or if the patient is having any ophthalmic surgery and you still continue this blood thinners, it is further going to cause bleeding and cause permanent blindness. So it is advised that you should stop them 5 to 7 days prior to surgery. You have to stop them 5 to 7 days prior to surgery. Now, you might think that, okay, we are going to stop it at least 5 to 6 days before the surgery. And we are basically giving blood thinners in the first place to this patient so that there will be decreased risk of chances of clot. So now what will we do in the meantime during this 5 to 6 days to prevent the chances of reinfarction? We are going to start with low molecular weight heparin like enoxaparin. So we are going to start with low molecular weight heparin like enoxaparin, and you have to stop this also because again these can also cause bleeding, right? So you have to stop the low molecular weight heparin at least 12 hours prior to surgery. And remember, you have to stop the, like if you're using a low molecular weight, that is going to be 12 hours prior to surgery. And if you are going to use heparin, a normal heparin which will be there, which is the regular heparin, you have to stop that 6 hours prior to surgery. You have to stop that 6 hours prior to surgery. Okay. So remember, in case of coronary artery disease, these are the questions which they might ask. Next, guys, so as I have talked about the minimum duration period for these drugs, let us talk about few drugs in which you have to know when do you have to stop it prior to surgery. The first thing which will be is aspirin. The first thing which is going to be is aspirin. Remember, guys, we are going to try to continue aspirin, okay? Unless you have a major risk of bleeding. Maybe a patient is already in the, like you got to know that he's having a history of using blood thinners, and maybe it's a very traumatic case like a thoracic involvement, abdominal surgery. Then you have to stop aspirin at least 3 days before. Okay, you have to stop aspirin at least 3 days before. Otherwise, if it is a minor surgery, please continue aspirin. Drugs like clopidogrel should be stopped and warfarin should be stopped at least 7 days prior to surgery. Ticagrelor should be stopped by around 5 to 7 days. An important PYQ is ticlodipine should be stopped by 10 days. Okay, the ones which I have ticked are these are the ones which have been asked previously in NEET PG and in Fmge, but make sure that if you just make a read through of these drugs as well. Okay. Next guys, hypothyroidism. Now why do you think hypothyroidism is dangerous? You know that thyroid is responsible for the maintenance of the basic metabolic rate. So in short, what is the role of basic metabolic rate with respect to anesthetic drugs? You know the BMR is going to control the excretion and the elimination of the drug. If a patient is having hypothyroidism and he or she did not take his drug, so the BMR is going to go low. If the BMR is low, the excretion rate and the elimination rate of the drug is also going to be low. So the anesthetic drug over here is going to be there for a longer time. Thereby, if a patient is on hypothyroidism, the chances of the drug to prolong its effect is going to increase. That is why you should continue the thyroid supplementation till the day of surgery. Okay. Next, if a patient suffers from a severe form of hypothyroidism, which is known as myxedema coma, you need to remember what is the triad of myxedema coma. It is a combination of three things as a triad: severe bradycardia, cold extremities, and patient is going to have hypotension. What are the three? Repeat after me. Come on. Severe bradycardia, cold extremities, and hypotension. Okay. If a patient has hypothyroidism also, you know, thyroid toxicosis increases the risk of patient hypertension, right? So what are the symptoms you will have? You will have tachycardia, hypertension, arrhythmia. It's kind of opposite to what you had in myxedema coma. Okay. Next thing is, if a patient is on any antipsychotic drugs. Remember guys, antipsychotic drugs should be continued till the day of medication, till the day of surgery, except for MAO inhibitors. Why antipsychotic? What if the patient has an anxiety attack just prior to it? So that's why you have to continue. But MAO indicators, like MAO inhibitors, are the ones which you have to stop. Why? Because they cause an increase in blood pressure, causing hypertension. The pathophysiology is over here because the MAO inhibitors are going to interact with some synthetic opioids like, you know, mepetidine or pethidine, causing hypertensive crisis. Thereby, remember, MAO inhibitors should be stopped at least 2 to 3 weeks prior to surgery. 2 to 3 weeks prior to surgery. Again, as I'm talking to you, this whole anesthesia is mostly ratification, and these are the most vital points which you should know. So make sure that at least if you're not able to understand some things, just understand that these are the very important topics which you have to get through in case of anesthesia. Okay. So remember guys, as I told you, in case of antipsychotics should be continued till the day of surgery, but MAO inhibitors at least 2 to 3 weeks before it should be stopped. There are drugs like lithium and drugs like magnesium sulfate. Where do you use lithium? Lithium is usually used in case of bipolar, and magnesium sulfate usually can be used in, remember we talked about in medicine, torsades de Pons, and along with that magnesium sulfate is the management case of preeclampsia and severe eclampsia, right? So in these drugs can also induce, they can prolong the muscular relaxant ka role. So remember over here, they have been also found out that they interact with the muscular relaxant, thereby the effect of these drugs are prolonged. But right now in recent guidelines, they say you can use magnesium sulfate. Along with that, the anesthetic can give it a clearance because you have to have, they can be continued. But along with this, remember, you should carefully balance its dose. The two drugs which I talked about, cis-atropine and atropine, mainly these two drugs, okay, cis-atropine and atropine, they have been degraded with the help of Hoffman degradation. So Hoffman degradation does not involve any role of the liver, okay, and that's why lithium also has some roles associated with the liver function test. That is why at the time, if you are having a patient who is on drugs like lithium or magnesium sulfate, if you are giving an anesthetic drug like cis-atropine and atropine, you can continue and give a clearance to the anesthetic checkup. Next guys, if a patient is on steroid therapy, what will you do? You will ask them to continue the therapy till the day of surgery. If a patient is on oral contraceptive pills, now guys, OCPs, you know there is a side effect of causing DVT, a deep vein thrombosis. If you have any low risk surgery, a minor surgery which will be there, you can continue with the oral contraceptive pills till the day of surgery. But if you have a major surgery, like a thoracic surgery is major, head neck is major, or abdominal surgery is major, you have to stop the oral contraceptive pills at least 4 weeks prior to surgery. At least 4 weeks prior to surgery. On the other hand, if you have a OCP, which is progesterone only pill, you can continue that, and there is no risk associated with DVT, okay, because DVT increases the OCP, which is responsible is estrogen. The factor is estrogen, right? If a patient is on anti-tubercular therapy, what you have to do is you can continue till the day of the surgery, but make sure you check the LFT. LFT should be checked, okay, because they also, like, you know, they have a role of hepatotoxicity. You already know that. If a patient is on any either Ayurvedic medication, which is herbal medications, they have a role in causing some abnormalities in the LFT. So thereby you have to check the LFT as well. If your LFT is normal, you can go on and proceed with the surgery. If you find any abnormality in a patient who's taking herbal medication in the LFT, stop and advise that reschedule the surgery from 1 to 2 weeks. Okay, they are metabolized in the liver. Get an LFT done. If it is abnormal, wait for 1 to 2 weeks. If a patient is on NSAIDs, okay, remember, if a patient is on NSAID, stop the NSAIDs 1 to 2 days before. Okay, if a patient is on diuretics, stop all diuretics 1 to 2 days before, except for thiazide diuretics. And remember, whenever you use any diuretics, make sure you check the serum electrolyte. Make sure you check the serum electrolyte. Okay, if a patient is on sildenafil, okay, which is used in case of like erectile dysfunction, you have to stop it at least 1 to 2 days before. Now you might see in the upper 4-5 slides, there are so many drugs when to stop, when to stop. So I just made a slide over here, which you have to remember all the basic things, and at least you can get around 4 to 5 questions pakka from here. Drugs and the time to stop these drugs just prior to surgery. If you have any person who is consuming alcohol, NSAIDs or sildenafil, tell them to stop it 24 to 48 hours before the surgery. MAO inhibitors should be stopped at least 2 to 3 weeks before surgery. If a patient is a smoker, because smoker causes bronchospasm or severely maybe laryngospasm, so which is not good for our anesthetic management. So that is why you have to ask them to stop smoking at least 6 to 8 weeks. Okay, this have come in the exam. 6 to 8 weeks before surgery. Estrogen pill, if it is a major surgery, oral contraceptives should be stopped at least 4 weeks prior. If a patient is on aspirin, try to continue, but again, if it is a very major surgery, stop it 3 days before. Clopidogrel, which we already discussed, 5 to 7 days before. Warfarin, again 5 to 7 days before. Ticlodipine, at least 10 days before. Stop all the diuretics except thiazide, and make sure you check the serum electrolyte. So as I was talking to you guys, smoking can cause side effects like, because it causes increased airway irritability, thereby causing bronchospasm, which can be checked on auscultation as wheeze, or it can be a laryngospasm, which can be checked as an inspiratory stridor. Implication, what we have to do is stop it 6 to 8 weeks before. What are you going to do for bronchospasm? You're going to give a short acting beta agonist, which is an inhaled beta agonist. What is the management of laryngospasm? This comes under anesthesia, so make sure you know this. What is laryngospasm? Basically is sudden closure of the glottis. Laryngospasm is usually seen at the time of extubation. Extubation, which means is when you're going to remove the endotracheal tube. Okay, so what you have to do is you have to remember the management. The management is, first of all, before the management, know what are the symptoms. You will have a high pitched inspiratory stridor, and since the airway is very closed, so obviously oxygen will not be there, so you will see the patient is desaturating. Okay, so remember, what is the management? You are going to give 100% oxygen. Along with that, you have to start Larson's maneuver. Larson's maneuver, guys, is you have to apply pressure at the styloid process. Okay, along with this, you are going to give a drug which is going to be injection propofol 10 mg IV stat. In some conditions where this is still not getting controlled with 100% oxygenation, Larson's maneuver and IV propofol, you can also give muscular relaxant like succinylcholine. Okay, talking about alcohol, why do you have to stop alcohol? Common sense, it can cause acute fulminant liver failure. So stop the alcohol at least 24 hours prior to surgery. Chewing tobacco, why do you have to stop it? Obviously, it is going to cause submucosal fibrosis. Correct? Last thing over here is allergic history. So whenever, what are the things around our anesthetic area which can cause anaphylaxis? Drugs like basically antibiotics, gloves, latex also can cause like anaphylactic or allergic reactions. Muscular relaxants, local anesthetics, because local anesthetics increase the release of histamine. Presentation is going to be, a patient is going to have a sudden tachycardia, hypotension, and in the airway there will be bronchospasm. What are you going to give? In case of anaphylaxis, the drug of choice is very good adrenaline. And adrenaline, which is also known as epinephrine, can be given in 2 forms. The dose which you get in the ampule is in 1 ml, you're going to get a ratio of 1:1000. If you're going to give it in the IV route, the route should be in 1 ml, 1:10,000, because it is going to be in IV, it's going to be very fast. So reduce the dosage, dilute it. In case of if you're going to give subcutaneous or IM, the dose is going to be 0.5 ml in 1:1000. Okay, so this is all the history with respect to allergy. So just tell me in the comments below, what is this triad when the patient comes with a history of bronchiectasis, infertility, and chronic sinusitis. So this is all with respect to part 1 of anesthesia, guys. Again, as you see, there is so much mugging up in this, some sort of explanation, but remember what we are going to discuss in this upcoming 4 to 5 video series is the most important things which you should not skip at the time of anesthesia. Watching these videos will make sure at least 4 to 5 questions in your exam is going to get clear. Thank you so much and see you guys in the next video. Bye bye.